I'm gonna send this stuff to his home. Oh, damn.
Is my audio working okay?
Yeah, I can hear you just fine.
My screen share is working?
I can see, yeah, I can see your screen. Yeah, it looks good.
Good morning. Morning.
Good morning, everyone. Welcome to this week's Medicine Grand Rounds. Just a few reminders since we're all joining remotely. Please make sure that your mics are muted to avoid any unintended interruptions for our speaker today. Please ensure your full name is on your Zoom login so you can be easily identified. And if you are logging in as a group, please email Department of Medicine Grand Rounds at hsc.wvu.edu to receive credit for today's lecture. If you have not participated and received credit for Grand Rounds via Zoom before, please complete the credit request form located in the chat box during the Zoom lecture. This ensures we have the appropriate information on file. We will save time for Q&A at the end, and if you type your questions in the chat, I will work to relay those questions to our speaker. We will try to wrap up around 8:55 in order to get back to our clinical duties. With that, today we welcome Dr. Christopher Dion. Dr. Dion attended undergraduate and medical school at Wayne State University. He subsequently went on to complete internal medicine residency here at WVU in 2018. He now serves as an assistant professor in internal medicine here at WVU, and he is integral to both medical student and resident education, including assisting with the Global Health Program. He is also actively involved in multiple different patient safety and quality improvement committees. We are thankful to have him here with us today to discuss acute care for incarcerated patients. Please join me in welcoming Dr. Dion.
Good morning, all. Thank you for the introduction, Dr. Catherman. This morning, I'll be talking about the inpatient care of incarcerated patients. This is my first Grand Rounds since joining faculty, and while perhaps a little less imposing than standing in front of all of you in Fukushima, it's frankly rather anticlimactic to be sitting at the same desk in front of the same computer monitor where I did most of my preparation for this talk. The community hospital is one of the least secured and controlled environments that play a major role within our criminal justice system. Many, or possibly even all of us, have taken care of an incarcerated patient at some point in our practice, but I would imagine that most of us do not do so frequently. This is an especially vulnerable population, made up disproportionately by other vulnerable populations, and their incarceration can pose unique challenges in their care. I have no relevant or really even non-relevant disclosures. While certainly not meant to be exhaustive, I hope to provide some information regarding the following topics. I'd like to familiarize you all with the applicable WVU Ruby policies regarding the care of incarcerated patients, discuss some of the unique circumstances of incarcerated patients that impact their care, discuss how care is delivered in the carceral environment, and discuss appropriate transitions of care for these patients. I'd like to start with a bit of terminology. As we care for patients in the hospital, we may encounter individuals across the entire time spectrum of their correctional process. Incarcerated is a general term referring to any person confined to a correctional facility. In custody refers to a person who is confined to or en route to a correctional facility. Inmate refers to a person confined to a facility. Jails are facilities typically administered by city or county level law enforcement and typically house individuals with a sentence of less than 1 year or who are still awaiting trial, undergoing trial, awaiting sentencing, or awaiting transfer following their trial to a longer term facility. Prisons, typically administered by state or federal authorities, generally house individuals who are serving sentences of more than 1 year. 6 states, Connecticut, Rhode Island, Vermont, Delaware, Alabama, and Hawaii have integrated jail and prison systems. Sometimes due to capacity issues, prisoners who would otherwise be in a prison due to their sentence length may be housed in a county level jail. Probation, parole, and supervised release are all terms referring to programs that allow some or all of a sentence to be served in the community. Clinicians should promote the use of not only accurate language, but also language free from stigma, which would avoid further disenfranchising these patients and prioritizing individuals. Globally, there are more than 10 million people in correctional facilities. Some estimates due to individuals within pretrial detention bring this number up to 11 million. In the United States, at any given time, at the end of 2019, 6.3 million were incarcerated. This makes up roughly 2.5% of the US population. While the number of people in prison in the United States tripled between 1987 and 2007, the US population has actually been declining since 2009. Black and Hispanic individuals are disproportionately represented among incarcerated persons, even further amplifying health disparities among these groups. While many of our patients have limited literacy and limited health literacy, these phenomena are known to be more prevalent in ethnic minorities and those of lower socioeconomic status. Both of these populations are overrepresented among incarcerated individuals. The incarcerated population in the United States is rapidly aging. With this increase in age, we're also seeing an increase in the prevalence of chronic diseases among inmates and an increased need for inpatient care. From 2010 to 2015, the percentage of those 55 or older increased by a median of 41% among the 44 states that report the statistic. People who are incarcerated also age at a faster rate than their peers, if one considers that they acquire comorbid chronic conditions and die at earlier ages than those who are not incarcerated. As we can see from this graphic, not surprisingly, West Virginia has one of the highest percentages of incarcerated people over the age of 55, and West Virginia is one of the oldest states in the nation. Incarcerated individuals are the only group in the United States with the constitutionally guaranteed right to health care. The Eighth Amendment reads, "Excessive bail shall not be required, no excessive fines imposed, no cruel and unusual punishments inflicted." However, it was not until 1976 that this amendment had guaranteed an incarcerated individual's right to health care. A landmark case, Estelle versus Gamble, regarded a Texas state prisoner, J.W. Gamble, who was struck by a 600-pound bale of cotton, which fell on him during a labor assignment. Gamble's back injury was not properly diagnosed or treated, and Gamble was subsequently punished for refusing to work due to the pain from his injury. This case eventually reached the US Supreme Court, and in their opinion, they held that, quote, "deliberate indifference to serious medical needs of prisoners constitutes the unnecessary and wanton infliction of pain as prescribed by the Eighth Amendment." In a decision by the 11th Circuit Court, a, quote, "serious medical need," end quote, is one that has been diagnosed by a physician as mandating treatment, or one that is so obvious that even a layperson would easily recognize the necessity for a doctor's attention. Deliberate indifference is demonstrated when correctional staff or treating providers recklessly disregards a substantial risk of harm to the patient. This reckless disregard holds a higher standard than negligence and is required that the actor know of and disregard. Some factors used to determine a, quote, "serious medical need," end quote, include whether a reasonable doctor or patient would perceive the medical need in question as important and worthy of comment or treatment. Secondly, whether the medical condition significantly affects daily activities and the existence of chronic and substantial pain. This shows that, quote, "serious medical needs" could include a broad range of not only acute, but also chronic medical issues that a physician believes requires treatment. Cases that followed established 3 basic rights for incarcerated patients, including access to care, which does include specialists or hospital care as required, the concept of ordered care, wherein treatment ordered by a provider must be enacted, and the concept of professional judgment, that patient care should be the general standard of care for any patient without any bias due to the patient's incarceration. The Eighth Amendment protection of these patients does extend to all clinicians, not just those that work in or are contracted by a correctional facility. Outside providers may be held liable as state actors if they deliver improper care to incarcerated patients. Of note, Eighth Amendment cases have not established or referred to any malpractice standards. These rights apply, of course, not only to medical care, but also extend to dental care and mental health care for incarcerated patients. Shackling is a general term referring to any form of restraint to control the movement of prisoners' body or limbs. Terminology with this can be a bit tricky, as sometimes leg chains or leg handcuffs are known colloquially as shackles. However, this term includes not only these leg chains, but also handcuffs and belly chains, which are typically used to further control a patient's handcuffed arms. It is important to differentiate shackles from restraints, which have a different definition within the clinical environment and are governed by CMMS guidelines. Whereas shackles are used for non-medical reasons, there are no CMMS policies for shackling in a care environment. Going forward, I will, or at least attempt to, use the term shackling when referring to non-medically required restraints, even though correctional staff and law enforcement do typically use the term restraints when they refer to these devices. One of the main concerns when an incarcerated patient is outside of the secure corrections facility is, of course, escape. Avoiding patient escapes, along with ensuring safety of staff, is one of the main reasons incarcerated patients typically remain shackled while outside of a facility. Hospital escapes do occur and have happened even in recent times here at Ruby. True statistics of hospital escapes or attempted escapes are difficult to obtain, as many correctional facilities do not stratify escapes based on their location, and hospitals may seek to avoid media exposure when these events do occur. In one study from the International Healthcare Security and Safety Foundation, they used media to track these escapes, and they documented 99 escapes from the hospital between April of 2010 and April of 2011. They did acknowledge in their study that the way they acquired these numbers using queries to news alert systems that were available through multiple search engines was a limitation, and the number of escapes that they obtained was likely an underrepresentation of actuality. In about 70% of these escapes, restraints had been removed from the patient prior to the escape, most commonly to use the restroom, to undergo a procedure, or to change into a hospital gown. Shackling can have drastic impacts on a patient's care. Patients may be unable to safely break falls when ambulating and can suffer reduced mobility while inpatient, resulting in an increased risk of thrombosis. Shackles can impede physical examination maneuvers and interfere with electrical grounding, an important concept when patients are undergoing surgery that uses cautery, undergoing defibrillation, or receiving an MRI. Correction staff can access non-metal restraints that should be used should the patients be undergoing any care that would preclude the use of metal restraints. Please know that keys used for most common handcuffs and ankle shackles are universal. It is important to not have any keys for these devices in your possession while working in the hospital. Similarly, these locks can be opened by skilled users using common metal objects to fashion lockpicks. Shackles, particularly handcuffs and leg chains, can also cause tissue injuries. With the picture on the left, the literature describes a patient who had actually initially presented for a mental health emergency, but was arrested and shackled when it was discovered that he had an outstanding warrant. This patient developed a stage 2 pressure ulcer of the wrist, which had presented itself at the state seen in the picture by day 2 of admission. This rapid time frame demonstrates the dangers that metal restraints can pose to our patients. Particular attention has been placed on the shackling of pregnant individuals. The shackling of pregnant women has been banned in federal custody since 2018, with this prohibition beginning on the date that their pregnancy is confirmed and ending upon their postpartum recovery. 22 states, along with the District of Columbia, also prohibit or limit shackling of pregnant inmates. And while these restrictions vary, some states only limit shackling during active labor. West Virginia law holds that pregnant inmates will not be shackled after reaching the second trimester until the end of their pregnancy, unless the inmate poses a threat of escape or a threat of safety to herself, the public, the staff, or the fetus. Should the inmate require restraints due to one of the above conditions, a quote, appropriate healthcare professional, end quote, will assure that the manner of restraint will not pose an unreasonable risk of harm to the inmate or to the fetus. A qualitative study of perinatal nurses in one acute care center demonstrated that patient shackling was negatively associated with healthcare provider empathy towards patients who were incarcerated. I was unable to find any other studies regarding care provider empathy and the use of shackles in a non-perinatal setting. As seen here in the WVUH policy, correctional restraints are not considered medical restraints and are to be selected and employed at the discretion of the accompanying corrections or law enforcement officer as per their own policy. Should there be concerns regarding the use or the type of restraints, the attending physician should speak first with the corrections or law enforcement personnel at the bedside. This issue may likely need to be escalated to law enforcement supervisors who may not be on site at the hospital. Should you need help with interactions with corrections staff or law enforcement for this or any other issue with an incarcerated patient, please reach out to Ruby Security, who interact regularly with these groups and are more familiar with policies and usual practices. As correctional restraints are not considered medical restraints per this policy, there may be instances when a patient requires both. This is especially important when one considers the tissue injuries as described that can be caused by correctional restraints, especially when great force is applied against them over a large amount of time. Some correctional facilities restrict patients from ordering privileges while they're in the hospital in order to mirror policies at their facility, where inmates do not regularly get to choose what they eat. Typically here at Ruby, this will be requiring the patient to receive a house tray of whatever specified diet has been prepared that day. Should the patient have a medically necessary reason to have the ability to, quote, order off the menu, discuss it with the correction officers at bedside and escalate as necessary. Entering a miscellaneous order may be helpful, but correction staff will need to be aware that there is a medical reason for this ability for them to order. We are all intimately familiar with HIPAA and its standards regarding the use and disclosure of individuals' protected health information. When initially proposed, HIPAA excluded inmates. However, this exemption was eliminated from the final version of regulations due to concerns that assaults on individuals with stigmatized health conditions may occur within the correctional environment. There were additional concerns that disclosures of an individual's protected health information may complicate patients' re-entrance into society following discharge. While incarcerated patients are generally covered under the final proposal of HIPAA, some exemptions do exist. A hospital is permitted to disclose protected health information to a correctional institution or a correctional employee if this information is necessary for the provision of healthcare to a patient, if the information is needed to maintain the health and safety of a patient or others at the correctional institution. Others that also may receive the PHI include transport officers or staff, or any provisions to maintain safety, security, and order at the patient's correctional institution. Regulations regarding substance abuse and mental health services, which require patient consent to the disclosure of substance use disorder treatment, do still apply to incarcerated individuals. Exempted PHI should be disclosed only after coordination with the medical officer responsible at the correctional facility. Frequently, incarcerated patients are interviewed or examined in the hospital environment within the presence of custodial officials. This obviously may inadvertently reveal PHI. One can ask the patient for consent before disclosing health information when correctional staff are present. Per this hospital policy, upon a care provider request, officers can stand or sit outside the doorway, which may ensure that a patient feels more comfortable disclosing information, and particularly information that may have disciplinary implications for them. While correction officers are necessary to ensure patient, staff, and facility safety, clinicians should adhere to HIPAA and substance abuse mental health regulations as much as possible, and privacy concerns should be communicated with the correctional staff at bedside. Clinicians and incarcerated patients, for that matter, often encounter a dichotomy with the contradiction between the patient's limited autonomy in many factors of their life while still having preserved autonomy in medical decision-making. Healthcare decisions are one of the few ways that an incarcerated individual can exert their autonomy and independence. With their relative lack of input in many other decisions that affect their life, inmates may be hesitant to self-advocate, and limited therapeutic choices often offered to them in less advanced care environments in facilities may diminish their ability to weigh risk and benefit, particularly in complex care situations. Also, it is important to keep in mind that for many incarcerated patients, their incarceration was the first time in their adult lives that they may have had consistent access to healthcare. As mentioned earlier, low levels of health literacy among this population may further complicate decision-making. Current research regarding surrogate selection for incarcerated patients is limited. Establishing surrogacy should be, when needed, should be done in a similar manner with incarcerated patients as we do with all others. Incarcerated patients face a unique set of circumstances that can often make it difficult to identify an appropriate surrogate. West Virginia state law regarding surrogate selection should be followed, and care management or a care managed supervisor can be contacted regarding this. Communication with outside surrogates can be similarly tricky, as we do not want to reveal the location of the patient, and something as simple as a provider name using an internet search can easily find that which hospital many of us work at. Having representatives from the correctional system act as a patient surrogate should be avoided, as this can clearly pose a conflict of interest. Even correctional physicians or clinicians who may have had a long-standing provider relationship may also have conflicts of interest in this regard. While family members are the most common surrogate choice for most patients, including those of other vulnerable groups, this can be especially problematic for incarcerated patients. Many have experienced estrangement from their family members, either due to their time away and separation as a side effect of their incarceration, or even perhaps due to the actions that led to their incarceration. As a family member who has not spoken with an incarcerated patient in some time, or not in meaningful ways, may not actually know the patient's most recent desires or preferences. This is compounded by policies that limit visitation, privacy, and communication, both in the correctional setting and when an incarcerated patient is in the hospital. These all serve as barriers to frank discussions between a patient and a potential surrogate. Instances may occur when a patient is refusing recommended care as a means of bargaining or protest. It is important, if one of these instances is suspected, for physicians to determine whether a patient is rationally refusing a recommended treatment or is making a decision for secondary gain or perceived secondary gain. Before any patient's stated wishes are overridden under this concern, it is important to consider involving hospital risk management, psychiatry, and/or ethics. I'd like to transition to how incarcerated patients receive care before they arrive in a community hospital, or if they are to be treated remaining in the correctional environment. A majority of the incarcerated patients I have cared for here at Ruby have been federal inmates. We have a low security facility here in Morgantown and several facilities ranging up to maximum security in Preston County at Hazleton. We have other federal facilities in more southern parts of our state. The Federal Bureau of Prisons uses a 4-tiered system to classify the level of medical care able to be provided to prisoners in order to ensure that individuals are housed in facilities able to cater to their needs. This is separate from their security level designation, minimum security, maximum security. Each prisoner is assigned a medical care level to assess where they will serve their sentence. All prisoners are housed in an appropriate facility at or above their healthcare level. This ranges from level 1, which are generally healthy patients with minimal medical conditions, perhaps diet-controlled diabetes, or mild asthma. Level 2 inmates are probably more likely most of our medical group practice patients who are stable outpatients who have one or more chronic conditions that do require periodic follow-up and prescription treatment. Level 3 inmates are fragile outpatients with cancer in remission, advanced HIV, or severe heart failure. And level 4 inmates requiring daily nursing care. These are ESRD patients, active cancer treatment, etc. Prisons at all levels are able to perform intake screenings to identify infectious diseases and any urgent medical or mental health needs, and provide at least basic medication and care for chronic conditions. The Federal Bureau of Prisons operates 7 federal medical centers or prison hospitals that provide healthcare services to prisoners with more serious medical conditions, either acute or chronic. This includes dialysis, oncology treatments, inpatient mental health, some surgical procedures, mostly orthopedic and general surgery, prosthetic fitting, long-term ventilator dependent management, along with dementia care and end-of-life care. The Bureau of Prisons will transport a patient into the community for healthcare when it cannot provide services through an in-person clinic or on-site at their facilities. The Bureau of Prisons does in some instances maintain contracts with community healthcare entities. Nationally, the Bureau of Prisons does have contracts for some imaging equipment, general medical and surgical supplies, as well as pharmaceuticals, but for all else, individual facilities contract on an individual basis. A 2017 report by the Government Accountability Office found that federal prisons located in rural areas are more heavily dependent on community medical care for their prisoners as compared to non-rural facilities. The Bureau of Prisons has historically had difficulties recruiting care providers in more rural areas. One factor cited in this is that Bureau of Prisons salaries are often not competitive with those in the private sector. As we look at this map, we see many federal prisons located in North and Central Appalachia, and many other facilities in other states and regions are in more rural and remote areas. Healthcare delivery in state prisons varies widely. A Pew Charitable Trust report from 2015 shows that $8.1 billion was spent on state prison healthcare in the United States. This made up approximately 20% of the state correctional budgets. Data from Virginia and New York show that even over 20% of their medical budget went towards off-site hospitalization. Off-site hospitalization is clearly an expensive proposition for state departments of correction. In 2016, the state of Virginia spent $62 million on off-site healthcare, with nearly half of that amount responsible for the care of just 179 inmates, which made up less than 1% of the state's prison population. Unlike in the federal system, not all states rely on directly employed providers for provision of care in their facilities. Some utilize contractors through third-party companies, while others rely on care from the state's university schools of medicine. Each state has different regulations regarding who has ultimate authority to send an inmate off-site for non-emergency care. Often, this has to do with their contracts with these third-party companies. West Virginia is a contracted state, where most of the employees caring for patients in the prisons work for an entity that is not the State Department of Corrections. North Carolina, Texas, and Georgia have taken a slightly different route. They have built their own prison hospitals, much like had been done by the Federal Bureau of Prisons. While upfront costs can be immense, ultimately this has helped control costs and made transitions from the hospital back to the facility much safer. These combined models and state prison hospitals has allowed for a standardized formulary and in some cases even standardized EMR. In Georgia and Texas, the same university affiliated medical groups that provide most medical care across the correctional facilities also operate these prison hospitals. The University of Texas Medical Bureau Galveston Hospital, which is their state-operated prison hospital, will accept patients from across the state. And due to geographical constraints of such a large state as Texas, these patients are often first stabilized in a community hospital before being transported to the state hospital. In North Carolina, all medical care within the Department of Corrections, including their correctional hospitals, they are directly employed physicians. Other states have modified floors or wings of hospitals into inmate-only areas. While the hospital staff is still utilized, the rooms have been modified and designed to meet security standards, and Department of Correction guards the unit. While upfront investment for these is also high, reduction in the needs of guards in each individual inmates' rooms has led to cost savings. Some states are also employing telemedicine and outreach screening strategies to help reduce cost. The state of Texas arranges 11,000 telemedicine video conferences a month, and they're second only to the US military in terms of their use of telemedicine. The state of Michigan has had a longstanding telemedicine program as well. Other states, such as South Carolina and Wisconsin, are partnering with state universities and medical schools to implement telemedicine programs within their Department of Correction. Many states periodically release mammography vans to perform this screening for their incarcerated population, allowing them to remain at their facility for these screenings. Some patients who have undergone these mammography screenings at their facilities have reported it was the first time they were ever screened. The American College of Emergency Physicians has specific guidelines for incarcerated and patients under detention. While this policy does pertain more to someone who has recently been arrested and likely not yet been to a correctional facility by their use of the word detainee, there are important considerations for those who are already incarcerated. This is partially due to the fact that a patient may not be able to see a medical provider at the facility until they've undergone intake procedures, which sometimes may not be able to do immediately. If an acute complaint is noted during these screenings, the patient may not be able to be seen in the facility until the following day, depending on sick call systems. Should a brief trial of a less intense care plan fail and a patient may ultimately require a procedure, this is another consideration for possible admission rather than discharge, as the patient may not be able to timely return to the hospital as would a member of the community. Disclosing discharge to incarcerated patients is a similarly complicated action. Providing details of information regarding patient transport can create a point of vulnerability for all those responsible for the transport, as well as community members, should a patient attempt an escape. Withholding discharge information is in contradiction with patient-informed discharge planning. However, in this unique circumstances, some middle ground can be reached. Certainly, any specific dates or times of follow-up plans should not be communicated to the patient, and instead should be part of a transfer of information to the medical provider at the receiving facility. WVU policy does allow for verbal discharge instructions, ideally without giving an exact time frame for discharge, or to occur concurrent with the actual discharge process to be provided to the patient. However, written instructions are to be given to the accompanying officers. It is vital that clinicians understand the capabilities of the receiving correctional facility to ensure a safe transition of care when a patient is being evaluated for discharge. Oftentimes, the services and treatments available in the facility differ greatly from those available in an acute care setting. Communication with the healthcare provider at the facility will be of great assistance, as it allows you to understand their capabilities and limitations. Well, for example, some facilities may be able to draw labs, but frequent testing and monitoring may not be feasible in that setting. Clinicians may also not always be on site at some facilities, instead being on call. Formularies differ from the discharging hospital to these facilities. The Federal Bureau of Prisons does publish its formulary online, but it is always best to confirm choice of therapeutic agents with the healthcare provider at the facility. Procedures regarding medication administration also vary greatly among facilities, and sometimes even vary within a facility based on a prisoner's security classification. As needed medications may not actually be available at all times. And while in some facilities, patients may be permitted to have some medications in their personal possession, this is often limited to small quantities of over-the-counter medications. In many facilities, there are scheduled med pass times, and it is important that this is a consideration as medication regimen is determined for discharge. I had a patient on my service last summer, and as we were determining pain regimen for discharge, we found that the patient's facility only passed narcotic medications every 8 hours, forcing us to choose a longer acting medication that we would typically not use inpatient here at Ruby. Without the diligent communication of my team, and mainly by my stellar sub-I at the time, with the facility's medical director, we would have been unaware of these constraints upon the patient's discharge. I've heard anecdotes regarding inmates not being able to carry their own personal albuterol rescue inhalers. Instead, these were kept in the infirmary, but I've been unable to find any specific guidance or regulations regarding this specific topic. Furthermore, availability of services such as hemodialysis or procedural care for patients should especially be confirmed before they're discharged. Much as the transition from hospital to outpatient or return to correctional facility is a high-risk transition, so is the transition from incarceration to general society. Individuals recently released from incarceration have high levels of poverty, unemployment, and homelessness. These individuals face challenges in securing housing and employment, reconnecting with family and friends, as well as abstaining from substance abuse. In a study published in 2007 in the New England Journal of Medicine, inmates released from the Washington State Department of Corrections, it showed that in the first 2 weeks following release, individuals were 129 times more likely to die from a drug overdose and 12 times more likely to die of all causes than were members of the general public. Another particularly difficult situation for patients is when they are being discharged from custody, especially if this is shortly following a hospitalization for a new or worsening health issue. Many of the incarcerated patients we see here at Ruby are federal inmates, and as such, may be from all over the country. Sometimes these prisoners know their release or parole date is approaching, as was the case with another patient I've treated in the past. And we worked to set up follow-up and ensure medical records were sent to a PCP in Iowa, where he anticipated returning to live with family following his approaching release. A study of inmates aged 55 years or older in San Francisco County Jail in 2012 examined acute care hospital use following release from custody, and it showed that having an identified PCP was associated with a 31% decrease in acute care hospital usage upon their release from jail. Ensuring access to primary care and insurance coverage for patients who are about to leave the penal system is of utmost importance and can reduce the burden on acute care system, as was shown in the San Francisco study. The Transitions Clinic Network is a national network of primary care resources for individuals with chronic health conditions who were recently released from incarceration. They are currently active in 14 states, as well as Puerto Rico. Each clinic involved in the Transitions Care Network employs at least one community health worker who has a personal history of incarceration. While not serving our state or any of our border states, at least not yet, this may be a resource for any of your patients within an upcoming release from custody. Further information can be obtained at the website that's in the bottom of the slide. While many clinicians may be concerned that medications they prescribe at discharge may be misused or diverted by incarcerated patients, there is no objective data or evidence that rates of diversion is increased among incarcerated patients versus those in the community. In fact, administering these medications in a monitored and controlled structured environment within the facility may even decrease diversion. While studies on this are limited, one study done on Rikers Island, which is a large urban jail in New York City, showed that only 6% of patients were discontinued over the course of the study due to concerns regarding diversion. This was for opiate therapy for pain. This falls within the relatively large range of diversion reported in many studies from the community. Studies do show that the most commonly abused substances during incarceration are the same as those abused within the community, mainly being alcohol and cannabis. Some psychiatric medications and GABAergic medications are somewhat more abused and diverted in the correctional facility than they are in the community, although we have seen more community abuse, especially of some of the GABA medications in recent years. Hospitals and healthcare systems are not the only entities interested in reducing readmissions. As the care of incarcerated patients in the community is expensive and labor-intensive, correctional facilities also seek to reduce their readmissions to the hospital. The State of California Department of Corrections, seeking to avoid readmission to acute care hospitals, first focused on their correctional facility with the highest rate of readmissions and then developed an algorithm to identify patients most at risk. They followed this with introducing a transitions program where inmates would have an appointment with a registered nurse 1 business day following their return from the hospital. After 2 years of this program, hospital readmission rate from this prison dropped from 9.3% to 2.4%. The vast majority of the country's state and federal prisons and county municipal jails do not offer any medication-assisted treatment for addiction, including methadone, buprenorphine, or naltrexone, Vivitrol, being the injectable form. However, this is changing. With the high burden of opiate abuse among those incarcerated, this is of obvious concern. Some facilities that offer these treatments limit them to patients who are receiving them before they were incarcerated, and few offer a choice of all 3 medications. Where these programs have been implemented, overdose deaths following release have decreased. Many cite funding and drug diversion concerns as reasons that they have not started these programs. And in a 2008 survey of prison medical directors, where all 50 states, the District of Columbia, and the Federal Bureau of Prisons were all queried, and all but the state of North Dakota responded, the most frequently cited reason against beginning MAT was that a, quote, drug-free detoxification, end quote, was preferred. Rhode Island is leading the country with the unique program where all 3 of these medications are available and offered to even to those who were not on MAT prior to incarceration. These therapies are also offered to recent arrivals who were using opioids in the community to help ease their withdrawal on arrival. Within 18 months of this program, overdose deaths among those recently discharged inmates fell by 66%. West Virginia offers medication-assisted therapy with IM naltrexone injections. These are given 2 to 3 days prior to release to inmates in all of the state prisons and 5 of the state's 10 regional jails. West Virginia Department of Corrections in the state facilities will assist participants in enrolling in Medicaid if qualified, and will also identify and schedule follow-up appointments for within a month of their release. The IM naltrexone is a monthly dosage. Follow-up provisions are less robust from our regional jails, though, and participation can be limited as many of those incarcerated there are awaiting trial or transfer to a state prison and not closely approaching their release. Our jail staff do not routinely assist with Medicaid enrollment, and many providers want proof of insurance to schedule follow-up. However, patients are given a list of local providers where they could attempt to arrange follow-up on their release. Of interest in this program in West Virginia, the IM naltrexone is paid for and provided by the manufacturer. While the West Virginia program does treat individuals as they re-enter society, we know that even our correctional facilities are not free from drugs of abuse. And programs like that in Rhode Island are likely a gold standard and will hopefully become more common. MAT locations within West Virginia's correctional system are shown on the right. Hopefully, as MAT becomes even more common within our communities outside, opinions of policymakers and correctional medical directors may similarly change. I feel like it wouldn't be a lecture in 2021 if we didn't touch on COVID, albeit just briefly. COVID-19 has disproportionately affected the most marginalized of our society, incarcerated individuals not accepted. The incidence of COVID infection in the carceral population has been reported to be 3 to 14 times that of the general population across several studies. The adjusted death rate is 3 times higher than would be expected if the age and sex distributions of the US population and prison populations were equal. Shackling may provide even an additional risk factor for these patients once they enter an acute care hospital, already prone to thrombosis due to their COVID-19 infection. Furthermore, shackling may limit the ability of the applicable patients to be able to awake self-prone. COVID outbreaks in West Virginia correctional facilities, especially those in Huttonsville Correctional Center, which sits 90 miles south of us in Randolph County, has placed an increased stress on an already limited healthcare system. Throughout West Virginia, correctional facilities are located in 26 counties. 10 of these counties lack intensive care services in their hospitals. There are 465 ICU beds in the remaining 16 counties where these correctional facilities lie. Specifically, in the case of Huttonsville, the surrounding 4 counties have only 44 ICU beds. Nearly half of the country's counties in West Virginia housing correctional facilities are below the average state poverty rate. I have a feeling that in many other states, data would show the same. Many of our incarcerated patients are being housed in areas that lack robust healthcare infrastructure, and the impact of these patients needing to rely heavily on community healthcare resources places an undue stress on those resources and the communities that they serve. Compassionate release is a term related to the transition of care of an incarcerated patient, where due to a severely debilitating or terminal illness, the patient may obtain early release. There are a range of policies and programs depending on what sort of custody the patient is in. This is typically done as community standard of care practices for end-of-life care are too intensive to administer in most correctional settings. All states, with the exception of Iowa, have compassionate release policies. However, guidelines do differ significantly. There are some barriers in the administrative process. This may often require prolonged review periods, which can set unrealistic timeframes in the setting of a terminally ill incarcerated patient. Providers may be asked to submit a letter stating their interpretation of the patient's condition. And there are several websites that offer templates of this should you need assistance. There's some special ethical considerations with this patient base. Incarcerated individuals are the least studied and the strongest protection groups of patients. Historical research on this population, including studies on the response to chemoradiation and pain tolerance, were abusive, to say the least. Due to these historical mistreatments, IRBs enforce strict criteria when reviewing proposed research of incarcerated individuals. Outcomes data is especially lacking, and much of the research I've presented thus far has relied on simple demographics data, which is openly reported by departments of corrections. Stringent IRB protection may limit the study of many aspects of this population, including medical care and outcomes. Organ transplantation and advanced therapies is a similar controversial subject. The first heart transplant to an incarcerated patient did not occur until 2002. This was a 31-year-old in the state of California who was serving a sentence for armed robbery, and he developed severe heart failure as a result of a viral cardiomyopathy. At the time, media outlets and the general public, there was outrage voiced that a convicted felon was receiving an organ that could have been used in another patient. Even today, a study of liver transplant centers showed that over a quarter of surveyed providers viewed incarceration as the single most controversial issue among determining transplant eligibility. Hard data regarding actual transplant numbers is lacking, as the organ registries do not contain information regarding incarceration status. Advanced therapies, especially ventricular assist devices, are also likely less utilized in the incarcerated patients, with cost and logistical difficulties in the correctional milieu that may make it more difficult to ensure success of some of these therapies. Cited concerns include general hygiene, inmates needing to possess backup batteries, and dietary considerations. With the literature regarding the treatment of incarcerated patients in the community being limited, as discussed, the medical education regarding treating this patient base is also lacking. Much of the learning we do is on the fly in the clinical environment. The rather obvious downside to this is that incorrect information easily propagates. As a medical student in Detroit, I was told by a senior resident that a prison warden would need to consent for a surgical procedure, something I now know to be completely untrue. We need to model correct and sensitive treatment and teach about the care of these patients and their special circumstances that can affect care. A multidisciplinary group is in the works of being formed to look into many issues here that often cause complications in the care of these patients at Ruby. This group will include representation from security, care management, nursing, and physicians. If anyone is interested in participating, please reach out to Dan Harris in Ruby Security. In conclusion, the provision of care for incarcerated patients in a hospital such as our own poses a unique set of challenges. Furthermore, many of us will do it only infrequently. I'd recommend that you all review our institutional policies regarding the care of incarcerated patients. I've included many of the pertinent highlights already in this lecture. While the guards at the bedside may seem well-informed, if something doesn't seem right, you can always ask to speak to correctional officer supervisor or contact Ruby Security. Ruby Security can also help with the escalation process if necessary. Provider to provider handoff and discussion can be especially more important in the care of these patients. And at least personally, I have always felt much better regarding my discharges of incarcerated patients when I or someone from my team has actually spoken with the medical provider at the patient's correctional facility. Thank you for your time. It's been a pleasure. And I'd like to open the floor for any questions or discussion.
Hey, Dr. Dion, thank you so much for your lecture. One of the things that I'd like to discuss is like the imaging or the labs that we usually order or recommend people to get in outpatient settings. I think if we do have an incarcerated patient, it may be a better idea to just get those labs or imaging done in inpatient setting, because once they leave the hospital, you don't know what kind of care or telemedicine provider they're going to have, and if they're going to follow up on the recommendations that we've suggested.
Yeah, I certainly agree with that. You know, a lot of times we will say, okay, they can get this done as an outpatient, but yeah, with this population, and really even some of our very rural patients that you know are not incarcerated, I'll do the same if I feel like access to follow up may be limited due to other circumstances. So certainly something to consider. Also, another instance where provider to provider handoff or speaking with one of the medical providers at the facility to see if this is something that could be performed or would be performed there would always be a good idea.
Hey, it's Katie Sechrist. I also wanted to thank you for this talk. It's very timely as we had a patient who was incarcerated with ARDS in the ICU just over the Thanksgiving holiday. And of course, I was involved communicating with the healthcare surrogate. And so I really appreciate that you touched on that, because it's certainly a challenge when we can't kind of go through things the way we typically do, in allowing the surrogate decision maker to see the patient. And one of the challenges that kind of came up was just communication. Like you said, we're not allowed to disclose location. We have to be very careful, you know, about even like identifying ourselves as much as disclosing their location. I'm wondering, one thing that came up was, you know, kind of how silly that was in that the residents weren't blocking the number when they called. Is that something we should think about doing? Just blocking our number when we call decision makers? Is that something?
Certainly it would be. And I would say kind of before any family is contacted, you know, guards at the bedside may not be the best source, but certainly reaching out to a shift lieutenant or shift commander at the facility to help kind of navigate what the best way to do this should always be done. Because certainly some of these patients, perhaps not the critically ill intubated ARDS COVID patient, but can eventually pose a security risk. Although I have seen some provisions for visitation in these sort of situations granted. Another thing that you can always, you know, escalate through correctional facility management to try to obtain. I had similarly, when I was on supportive care as a resident, we had a terminally ill pontine stroke in the SICU. And this patient was actually, family were allowed to visit, and the patient was eventually compassionately released. But yeah, certainly always kind of contact Ruby Security, find the best ways to do this. But yeah, we need to be very careful, because even if I were to simply Google search you, Katie, I'd find out that you work at Ruby Hospital.
Yeah, especially those of us that are in specialties where there's not as many of us. I think that that's something that we need to be very thoughtful about. Thank you so much.
All right, well, we're quickly approaching 8:55 here. If there's no other questions or discussion, thank you all for your time and allowing me to present on this important topic that I don't think I certainly learned a lot preparing this, and don't remember getting this much education on this topic before.
Thank you, Dr. Dion.
Thank you.